So you may start the session.
Good afternoon, doctors, and welcome to this program of latest Urticaria guidelines from Heathrow. Heathrow Healthcare, doctors, as you know, is an innovative pharmaceutical company. Our journey began in 1993. We have 30 years of excellence, 36 state-of-art manufacturing facilities. We have around 300 products in portfolio and presence in 726 plus countries, with 21,000 employees globally. We are the largest closely held pharmaceutical company. We are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. We have Asia's largest manufacturing facility complex at Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and we have distinction of bringing 4 biosimilar products to market within 5 years of initiation: darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Heathrow Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir, for which Heathrow Healthcare received Award of Pharma Excellence in August 2020 for COVID drugs. Now, these guidelines, latest Urticaria guidelines, we all know is Urticaria is a condition which is seen very commonly in our day-to-day practice. There are many literature and many guidelines published, but we like to have our own doctors' insight on the Urticaria guidelines, their opinion about Urticaria guidelines, for which we have got experts today: Dr. Kiran Godse, Dr. Abhishek Dey, Dr. Senthil Kumaran, and Dr. Indrashis. Welcome, doctors, to this webinar. Dr. Kiran Godse, as we all know, sir, is MD, PhD, FRCP, Professor of Dermatology Department, DY Patil Hospital, Navi Mumbai, India. Sir has been President IDVL 2020 and President Skin Allergy Society, past Editor-in-Chief, Indian Journal of Skin Allergy. Dr. Abhishek Dey, sir, is MD, FHE, SCC, Dermatology, FRCP, Edinburgh, FAAD, and PhD. Associate Professor, CNMC, Calcutta, Associate Editor, Indian Journal of Dermatology, Managing Editor, Indian Journal of Skin Allergy, Assistant Editor, JCAS, and member of SIG Small Molecular and Biologics. Welcome, Dr. Abhishek Dey. The next speaker is Dr. Indrashis Poddar. Sir is MD, DNB, MNAMS. Assistant Professor, Department of Dermatology, Salgori Datta Hospital, Kolkata. Deputy Editor, Indian Journal of Dermatology, Assistant Editor, Content Editor, IGDVL. Dr. M. Senthil Kumaran, sir, is MD, DNB, MNA, MS, FRCP. Sir has Professor, Department of Dermatology, Venereology, and Leprology, Chandigarh. Sir is Editor-in-Chief, Pigment International Journal, Section Editor, Frontier Journal of Allergy. With this brief introduction, I hand over the section to Dr. Kiran Godse for further deliberation. Welcome, sir. I'll stop sharing and we can take it.
Yeah, welcome to this Urticaria Guidelines webinar. This is the webinar about what are the new Urticaria guidelines which were just formed in December 2024. And all the 4 on the dais, we were part of these guidelines. Myself, Dr. Abhishek Dey, Dr. Senthil Kumaran, and Dr. Indrashis. So I'm going to, in brief, tell you about 15-20 minutes what are these new guidelines, what is changed and what is new. And then we'll have a panel discussion moderated by Dr. Abhishek Dey. And audience can send their questions and queries on the chat box. We'll be happy to answer. So last 10 minutes will be for a question answer session. So we all know urticaria is a disease which is easy to diagnose but difficult to treat. Well, Urticaria guidelines from India were made in 2011 by IIDVL SIG Urticaria Group, in 2018 by Skin Allergy Society, and 2023 new Urticaria guidelines by Skin Allergy Society were published in Indian Journal of Dermatology. So urticaria is easy to diagnose, difficult to treat. Anybody can know it's the red itchy wheals which comes and goes. But remember, the wheals lasting for more than 24 hours, please take a biopsy. Use mobile phone to take serial photographs. Angioedema is the edema swelling of the lower lip. There is always pain and burning and less of itching. Again, angioedema without wheals, please think of hereditary angioedema. So urticaria can be acute and chronic. We all know 6 weeks is the cutoff period. Chronic can be further divided into spontaneous and inducible. And spontaneous has got many causes like autoimmunity, allergy, infection. So we'll be talking more about the chronic urticaria. Acute urticaria you have to treat with the full dose of antihistaminics and sometimes steroids. 1/3 of acute urticaria patients may become chronic. Few patients, the urticaria can last from 6 months to 20 years. So urticaria, spontaneous urticaria is the one which troubles. Inducible urticaria is a different chapter. Patients can tell what is the cause. Typically, dermographism, direct patient urticaria, cholinergic urticaria is the commonest one. The new endotypes of urticaria, this is from 2020. The new ones are autoallergic and autoimmunity is the old one. So typically chronic urticaria, the mast cell is triggered by autoallergens and by autoimmunity. So if you can see this diagram, the autoantigen, that is Ig anti-self, can trigger mast cell through BTK pathway. Similarly, autoimmune antibodies can also trigger through Fc epsilon R1 pathway. And MRGPRX2 is a new upcoming pathway which also can trigger mast cell to release histamine and variety of mediators. And final result is pruritus, erythema, edema, and wheal. Autoallergic is the more commoner type. It is auto-Ig against TPO, TG, TF, IL-24, dsDNA. And autoimmunity is type, classically is IgG type against Ig and Fc epsilon R1. Diagnosis is by auto-Ig and specific Ig for autoallergic, which is not available easily. But autologous serum skin test is available for autoimmune type. Ig is higher in allergic type and low in autoimmune type. And typically, disease is less severe in autoallergic and severe in autoimmune type. The fallacy is most patients with chronic autoimmune urticaria also have autoallergic urticaria. So combination can occur, but vice versa is not true. Urticaria activity score is easy to find out how is the severity of urticaria, count the number of wheals and the intensity. And you can actually see that anything between 28 to 42 per week is a severe urticaria. So that's why you can actually record the severity of urticaria. And urticaria control test is a 4-question test. And anything more than 12 means urticaria under control. So these are simple tests available on the Cruise app. You can tell or you can do it in your clinic. Well, average duration is 1 to 5 years of urticaria. Typically, 50% will resolve in 6 months, 20% in 3 years, and 20% in 5 to 10 years. And 2% will have it for 10 to 20 years also. So typically, first year, if you treat aggressively, patient may get remission at the end of 6 months to 1 year. The factors which can worsen or those factors, these patients will need something beyond antihistaminics. These are those with more severe disease, longer duration, females with age more than 50, concurrent angioedema, inducible urticaria, BMI more than 32, smoking, metabolic syndrome, NSAID, hyperreactivity, associated rhinitis, asthma, and polypharmacy. So these are the patients will have a urticaria which are of longer duration. They need more beyond antihistaminics, something maybe cyclosporine or romalizumab that we'll see in the next few slides. Why urticaria is a bad disease? Because patient can't sleep, they can't concentrate, they can't work, they become moody, irritable. Just imagine when I'm talking, I get itching on the wheel or swelling of the lip, what will happen to me? So that kind of same fear patient has got. And that's why this is a bad disease, because whole world can see your disease. So it affects almost every burden, every aspect of your life, physical, social, economical, emotional, and role function relationship. So typically patient needs a meaningful patient engagement and obviously more of sympathy and empathy to understand the disease. So these are the older guidelines 2020 which are published 2020 December. Start with antihistaminics, make it 4 times. If no response, add omalizumab. If no response, increase the dose or add cyclosporine. This is the guideline. Please understand, when you give 1 tablet of antihistaminic, only 50% patient will come under control. When you give 2 to 4 tablets, 50 to 70% will come under control. When you add omalizumab, almost 20 to 80% patient will come under control. 10 to 20% patient will not respond even to omalizumab or cyclosporine. So that's why you need a variety of treatment and variety of ways and means to control the disease. Now, this is new guideline 2024. It is not yet published, but what is being new here is, apart from omalizumab, they have added dupilumab and remibrutinib. They have not yet sanctioned FDA or DCGI approved for urticaria, but they are likely to get approval by end of December 2025. That is the expectation. That's why they have added it here. Otherwise, it virtually remains same like the older 2021. So the newer biologics and biosimilars and small molecules will actually rule the urticaria. These are our Indian guidelines. We say that you can use updosing, but you can use a combination. You can add H2, that is ranitidine, and you can add montelukast. And apart from omalizumab and cyclosporine, you can add methotrexate, dapsone, and autoserum therapy. So these are all options for the patients who can't afford the omalizumab and cyclosporine. So UCT score, if the patient has got UCT score of 16, that is complete control, you can step down the antihistaminics. And if it is less than 12, you need to increase the dose. So this is a step down therapy. When there is a complete control of urticaria for 2 to 3 months, you can step down. Don't be in a hurry to reduce it. So tapering is every 2 to 3 months and not, there is no hurry at all. So that's a step down therapy. Low IG is those patients will respond to cyclosporine better, and those patients with high urticaria activity score, high CRP, high D-dimer, concomitant inducible urticaria, or with steroids, these patients will not respond to secondary antihistamine. Well, Bilastine is the latest molecule which we know, which is the one which is the safer without any sedation, and it is actually now ruling the Indian market because it is available in already 20 and 40 mg doses. And why it is safe? Because H1 occupancy receptor, Bilastine and fexofenadine are the only two drugs which do not penetrate the brain. Otherwise, all the other drugs can penetrate the brain and causes sedation. So the safety is important. So that's why we say that the newer antihistaminics like Bilastine and fexofenadine are the safer one for long-term treatment of urticaria. Sedation with antihistaminics can create a poor sleep architecture. So when you give antihistaminics like hydroxyzine in the night, REM sleep is delayed and patient remains drowsy. Omalizumab is a drug which is available in India, 300 mg once a month for 3 to 6 months. A biosimilar is economical. It does not cure urticaria, but it gives long remission and better quality of life. Well, every patient do not respond. Those with BMI more than 32, low IG, positive anti-TPO, basopenia, eosinopenia patient will not respond or will take longer time to respond. And sometimes a combination with cyclosporine is needed. Cyclosporine is effective. You can give it 2 to 3 mg per kg and reduce check CBC, creatinine, blood pressure. Obviously, you cannot give beyond 6 months this drug. So we can give 200 mg first month and gradually reduce. And then there is a weekend cyclosporine therapy you can add to control the disease. The weekend cyclosporine therapy is being, the PGI Chandigarh has already published few studies on psoriasis. So you can use same principle for Indian urticaria patients. Corticosteroid do not give continuously, 20 to 30 mg per for 5 to 10 days for the flares is important. Don't give betamethason or prednisolone routinely. Use it only judiciously, and don't give continuous steroid therapy because the steroids are more damaging than the urticaria. Tofacitinib is available economical immunosuppressant. It's a pan-JAK inhibitor. Dose is 5 mg twice a day. Investigation must. Please rule out tuberculosis. Obviously, it is not as good as cyclosporine, but you can try it if you cannot, because it's one of the most economical immunosuppression available in India. Workup, basically you do these 4 tests: CBC, ESR, CRP, and total IG anti-TPO. IG, a high total IG indicates autoallergic type, and low IG indicates autoimmune type. CRP, high CRP indicates autoimmune type of urticaria and not non-responder to antihistamine. CBC with 5-part cell differential, a basopenia and a eosinopenia both are indicator of autoimmune urticaria. Similarly, lymphopenia is also a marker of autoimmunity. Positive IgG anti-TPO is a marker of autoimmunity. So by doing this test, we know whether patient is autoimmune type or autoallergic type. Well, you have to avoid the triggers. 3 drugs, I'll tell you. Again, look for thyroid hormones and autoantibodies. Look for tryptase if you suspect mastocytosis, and do a biopsy if you suspect vasculitis. So confirm the diagnosis, look out for the causes, look for the triggers, look for the comorbidities, look for the consequences, and obviously monitor the activity with US and UCT. That's the best way to treat this disease. So this is algorithm. Again, a patient with hives or urticaria, if patient has got unexplained fever, joint pain, body pain, malaise, please think of autoinflammatory syndrome. Hives lasting for more than 24 hours, please think of vasculitis, and symptoms are inducible, think of inducible urticaria, otherwise it's a chronic spontaneous urticaria. So these are the 3 drugs can trigger urticaria. NSAID can trigger within few hours to 7 days. ACE inhibitor can trigger more of angioedema in 3 to 6 months type. And gliptins also give bullous pemphigoid-like lesions to urticaria lesions. So please ask for this history when patient comes with urticaria to you. Other options are Montelukast, ranitidine, methotrexate, dapsone, autoserum therapy, and doxepin. So Montelukast you can always give in respiratory allergy and in NSAID into urticaria. Ranitidine is a simple antihistaminic H2 type. It works 150 mg twice a day, or famotidine you can give. So those patients, this is a 7-tablet formula for urticaria. If you are really not sure, please give these 7 tablets and your 70% patient will come under control. So for H1, 2 in the morning should be Bilastine or fexofenadine, 2 in the evening can be levocetine or loratadine, 2 of H2, ranitidine or famotidine, and 1 of Montelukast. And to add to it, now we know that vitamin D3 supplementation is important. Those are deficient, and in B12, especially vegetarian patients. Methotrexate give 10 to 20 mg per week. Obviously, it works. Slow work takes 1 to 2 months to show the effect. Mycophenolate mofetil is slow act but very safe. Dapsone works more for arterial vascularitis and dilatation urticaria, 100 mg per day. Autoserum therapy is a poor man's biologic. Give 2 to 3 cc every week for 9 weeks. Subcutaneous or intramuscular. Well, patient like injection therapy and you can do it in your clinic. In children, we can use same algorithm like adults. Only thing is start the lower dose and slowly increase. In pregnant and lactating women, give loratadine, levocetirizine, cetirizine, desloratadine, and fexofenadine. These are the safe drugs, but no updosing is advisable. And typically, patients of urticaria in pregnancy, most of them, they do respond. One-third patient can worsen. Well, what's new in urticaria? We have already seen dupilumab will officially get approval for urticaria, as well as remibrutinib is a BTK inhibitor, and other drugs are in the pipeline. So next few years, we'll have only these two drugs to work with. But there are a lot to come in the Indian market for urticaria. So summarizing, second generation antihistamine is the first line. Omalizumab is second line, cyclosporine is third line, and there are newer biologics like remibrutinib and dupilumab. Well, the good news is International Urticaria Conference will be held in Navi Mumbai on 4 to 6 December. Typically, it is meant for urticariologists all over the world, and we'll soon get the website and details about it. This is one of the biggest conference of urticaria in India. Well, there's a Cruise app. Those patient net savvy, they can download and do US and UCT, and there is a dedicated Indian Journal of Skin Allergy where you can publish or read what is latest. I think that's all from my side. This is just a short, brief summary of what is new in urticaria guidelines. Now we have Dr. Abhishek Day, who will ask the questions to the panelists, and obviously audience can send their own questions to us, and let us make this an interesting this thing. Over to you, Dr. Abhishek.
Thank you, sir, for the nice summary and almost everything you have covered, but still we need to emphasize certain points. So I'll share my slides. Hopefully it's visible. You can see it?
Yes.
So these are my conflict of interest, but nothing related to this particular talk. Welcome, sir, and all of us were there together, and sir actually presided many of the part of the meetings. So these are the beautiful photographs from the Galen meeting, UCAR meeting we had in Berlin recently. So 2 days or 3 days of constant lot of academics and a lot of debates. As you can see, we are holding this green and red cards for either approving or disapproving as some part of the guidelines. It has like been personal memorable also because we could kind of start some of my books over there. So it was nice to find my senior international colleagues and give a copy of them. And then we had a little bit of fun, and all those people are here today. Hello, sir. Hello, Indrashis. Welcome back. So,
Nice memory.
Yes, sir. So the buzzword now to identifying endotypes, because possibly now we are going towards some era of articular treatment where biomarkers are getting increasingly important. Sad briefly touched on that, but Indashis, can you just say how do you recognize in a simple, you work also in government medical college or you have a private practice. So in a simple diagnostic test in case of chronic urticaria, do you need to do some test, and why you need to recognize the endotypes, and what are the tests you'll be doing for that?
Okay, thank you. So I think I'm audible. A very good evening to everybody, and all the delegates who have joined here. So of course, this is very important, and as Kiran sir has already mentioned, that there are two endotypes now, type 1 and type 2. So type 1 has more of the IgE antibodies, and type 2 has more of the IgG antibodies. So the easiest thing to do is that we do the serum Ig level, total serum Ig level, and the IgG anti-TPO level. So, and this ratio is important. If we find that the Ig level is high, and the IgG anti-TPO level is low. So that means it's positive. It's indicative of type 1 autoimmunity or type 1 endotype. On the contrary, if IgG anti-TPO level is more and IgE level is low, so that means it's a type 2B autoimmunity or type 2B endotype. So how I remember is that as 1 comes before 2, so if IgE is raised, so that's type 1, and if IgG is raised, that's type 2. So this is the simplest form, and as we will see in the recent guidelines, this has already been come up that we should do it in specialist centers. That's where we all are. In specialist centers, this should be done for every patient. And implications on the management, yes, Kiran sir has also touched upon that. To make it short, type 1 endotype patients are more responsive to omalizumab. This is also easy to remember because type 1 has more of IgE, and we know omalizumab is anti-IgE. So just to make things simple, this is not how it works, but to make things simple and for easily remembering, we can remember that type 1 has
Yes,
more IgE, so
yes,
omalizumab is more effective. And in
yes.
type 2, cyclosporin is more effective.
Yes, Sandeep sir, in the same context, I just need to know from you, straight from the guidelines, do you think that recent guidelines, which will be published very shortly, will have this endotypes will have any implication? Will will we be treating urticaria first, identifying the urticaria endotypes, and then choose what molecule to be chosen?
That will be the easiest way, because if the newer ones are coming into the market, they are going to be costly. So rather than blindly implicating the something on the patient, it's better to, like what Indresh has said, try to classify what is the endotype which you're dealing with simple tests like IG and things like that. And one more thing is, usually an IgE mediated, that is an autoallergy one, responds some to antihistamines, like how Kiran sir said, like around 40% response to one dose, and nearly 60 to 80% will require an updosing. But at least somehow they will respond. But if the autoimmune type, no, they usually require a very high, that is 4 doses of antihistamine and more than that. So that's one place where that will help a simple way without any test if you want to classify it's an autoallergic. Otherwise, like how Indrashi said, IgE, you do can be able, where the IgE is more and the anti-TPO is less, then it's more of an autoallergic type. But nowadays there are papers which says that a patient can have both things together also. That is one thing.
So type 2 may have a traces of type 1, but type 1 will not always have will not have traces of type 2. That I think
Yes.
Sir wanted to mean. That is understandable. So I mean, to cut the story short, we know that when we are studying, we always used to know all allergies like asthma, urticaria, and everything is like anaphylaxis. That type 1 hypersensitivity reaction, which is basically IgA dependent type 1 immediate type of hypersensitivity reaction. But now our understanding changing as we identify a subset of this type 1 hypersensitivity, which also have a features of type 2. Now that's type 2, we always knew that this is cell-mediated immunity and it's kind of cytotoxic. But this type 2B actually doesn't destroy the cell, rather modify the function inside. And therefore, we still have this urticaria-like lesions, urticaria-like lesion, but then this is a different and more chronic and more delayed type, more long-lasting type. And at times, there can be suggestion that molecule like cyclosporin or molecule like maybe remibrutinib, those can be more effective, a little bit higher in case of type 2B autoimmunity rather than type 1, which is the omalizumab's kind of will be a bit more effective. Sir, Kiran sir, I'll come to you. In diagnosis of CSU, is any changes expected? How we'll approach a case of urticaria? Like we always been acute and chronic, and then in chronic inducive urticaria, chronic spontaneous urticaria. You showed a beautiful flow charts which we use for diagnosis for a long time. Like I think last 2-3 guidelines we have been using. Any chance this approach will be changes?
No, not actually. Urticaria diagnosis essentially remains same, and 6 weeks cutoff also remains same. Although there is some school of thought where they think that 6 weeks is too short, and maybe 2 to 3 months. But anything more than 3 months is a chronic urticaria, and typically patients diagnosis. In fact, I many times insist that take a biopsy if you suspect there is a vasculitis. So that is what all dermatologists, if they can take a photograph on cell phone every 12 hourly, and at the end of 36 hours also you can see a hive, please take a biopsy, because then the treatment already changes. That is one thing we have to think. Otherwise, essentially, the things are remain same. Thank you.
So, couple of few 4 5 simple questions, and most of the time our diagnosis is reached. The testing is most not usually for the all the blood tests we are talking about, like CBC, 5-part analyzer, all those things we are talking about is mainly for the prognosticating and try to find out who will be right treatment for the patient. But diagnosis is usually very simple, whether the patients have any associated symptoms, think about something else, is the patient hives are lasting for less than 24 hours, more than 24 hours. If it's more than 24, think about something else. If the patient's symptoms are inducible, try to find some inducing agent and, kind of with provocation test and try to eliminate those. With this simple kind of questionnaire, we can lead to this either diagnosis of chronic spontaneous urticaria, chronic inducible urticaria. Industries, what do you expect for acute urticaria and chronic urticaria? What are the basic laboratory tests should be done? I mean, we know what is happened in the past guidelines, but what will be these guidelines will be suggesting?
I think we all went there, and I think everybody agreed that this remained the same, that no tests are recommended in case of acute urticaria. And in case of chronic urticaria, we can do a complete blood count, a 5-part, as Kiran sir mentioned, because besopenia, eosinopenia are important markers of therapeutic response, and total IG and anti-TPO. Though there are schools of thought which say that IG and anti-TPO can be done if the patient fails to respond to antihistamines, because anyways it doesn't affect our giving of antihistamines. It can affect the prognosis to some extent. But anyways, if you go by the guideline, what it says is acute urticaria, no further investigations are needed. It's a very acute condition. And in case of chronic urticaria, we can do a complete blood count with ESR or CRP, because these will be able to rule out the autoinflammatory syndromes, and anti-TPO and IG, as we have already discussed. But I think in case of acute urticaria, in case of children, especially children less than 5 years, then we have to consider the food allergy, because food allergy is common in children less than 5 years, and urticaria may be a manifestation of food allergy. And in those cases, if the history suggests, we need to do those kind of tests to rule out food allergy, like specific IG and the skin prick test. So these are in the very specialized centers and in special scenarios. But in general, I think acute urticaria, no test; chronic urticaria, complete blood count with ESR or C-reactive protein, anti-TPO IgG, and total serum IG.
Acute urticaria, as you rightly says, is most often usually induced by some viral or some other infective markers. So that's why usually it's self-limiting in 4 out of 5 patients. So you do not need to do a lot of tests. Most of the patient, if it's recurrent acute urticaria, you can identify using a simple food dairy. What are the food which can be causative? Many times it's not the right food, but rather some food additive like yellow color or orange colors, or something like that. Those are the coloring agents. All those things can be implicated, but these are the rarer part of that. Most often it's chronic urticaria, which is we see the bulk of the patient, doesn't have anything to do with food. There are some suggestion that is less than 2% of the total urticaria. So rampant food testing may not be required, but as in the some select like industries and Kiran sir and Sendil sir all have a UCAS center, they may do some testing that can be done. Sendil sir, I'll come to you for a very specific thing, because you amongst all of us, you tend to have the liberty of working in a very reasonably upscale setup. So the tests which have been often suggested, like anti-IG, IG anti-TPO antibodies, basophil degranulation test, these are the tests are suggested to find out whether it's a type 1 or type 2B. That is one thing is regularly getting suggested, apart from the ASS doing. And also D-dimer test, things like mean platelet volume, those things are also suggested by some guidelines that they may have, some biomarker. They can be also biomarker for identifying the endotypes. Sir, do you do this test? Do you have the facilities? Do you do any test like that regularly?
Yes, Abhishek. Let me come from the first one. I go with your thought like when you told about the duration of acute urticaria. Last time during the consensus meeting, I was talking to a few people. They were actually telling like what Dr. Kiran was telling, we can keep up to 2 to 3 months. 6 weeks is quite less. That is one thing. Anyway, there is difference of thought, but anyway, anything above more than 2 months can be taken as a chronic spontaneous urticaria. That is one thing. And coming to the test per se, more since being a referral center, patients commonly who have been suffering for 3 years or more only most of the time land up in PGI, and we do end up doing few tests. That is, whatever test we do is we do the serum IgE, we do the anti-TPO, we do the D-dimers and serum vitamin D. These are the 4 tests along with the regular CBC and CRP, whatever you do, the extra. Now, why D-dimers have done is we have seen that in the autoimmune, the type 2B, the D-dimers are raised. We have assessed and we have published this data also. So wherever the D-dimers are raised, they are usually refractory to they require more than 4 times antihistamine as well as cyclosporin for them to come under control. And in few patients, we did see the role of tranexamic acid. This we have published in the, I think, iDodge, that those who are having D-dimer thing, they do show some derangement in PT-INR and things like that also when you future thing, and they do well with tranexamic acid. And the other thing about the basal granulation test, we have started the basal granulation test, BHRA over here in our lab. We have standardized a few of the values and we are analyzing our results. So we have taken the positive controls as the normal CSU and the negative controls as the normal control population, and we have made a cutoff value and we are analyzing our results. Will be quite soon, we'll be publishing it. Like then probably it will be a much better way to tell after that.
Great, sir. Great, sir. Great, sir. Great, sir. So these are things already sir has mentioned, so I'm not going into details. These are the from the last guidelines. Comorbidities with urticaria, that is something very commonly asked about these things. Kiran sir, we always knew the allergic comorbidities. You can also talk about those things, but what are the other comorbidities which we tend to identify with urticaria recent times? Was there any discussion about that happened during the guidelines meeting?
Yeah. So we now realize that metabolic syndrome, BMI more than 32, all these patients are the patient are tough to treat. So metabolic syndrome, thyroid disorders, and allergic disorders. These are 3 common associated comorbidity, and there are many more which are being coming out. But these 3 you should look for and look for do the special screening just to rule out blood pressure or hypertension. This is what you have to look for. So other diseases are like vitiligo, all autoimmune diseases can coexist with autoimmune urticaria. So it's important that you must rule out the autoimmune nature is indicator that there could be some other diseases. Thank you.
Also, so there are certain suggestions that even obesity, metabolic syndrome, like in many other conditions now, psoriasis and atopic dermatitis, there are some relationship even with depression. All those things have been kind of found out, but overall, most common connections is with allergic disorders. That's and some of the autoimmune disorders, especially in the type 2B urticaria. So there are some suggestions that in psychiatric comorbidity in CSU patient is very common. Even if there's no comorbidity, if you do the DLQI, and Kiran said knows that we recently had sent one article to International Journal of Dermatology for evaluation that DLQI is really kind of hampered in case of urticaria, and that tend to correlate with a lot of factors, not only the severity of the disease, but also the endotypes also. So those data we have sent recently to International Journal of Dermatology is getting done a review. Diet and CSU industry briefly touched upon that. Do you routinely suggest any dietary modification for your patients?
No, I think the answer should be absolutely clear. It is no. As you have already mentioned also, we should not routinely prescribe dietary modifications or dietary restrictions to urticaria patients. Because as you have already said that barely 2% of patients will have IgE-mediated food allergy, which causes urticaria. So that is very, very rare. In the remaining of the patients, if we find that the patient is not responding to your conventional therapies, and conventional therapies here means not only antihistamines, cyclosporine, then the other kind of immunosuppressants, even H2 antihistamines. So after exhausting all of these things, if we find that the patient is not really responding, the patient remains refractory, then we may try to restrict the pseudo-allergens, which you have already mentioned, the food additives, the different coloring substances, the different kinds of dyes in our food. So I think only in such refractory patients, you can always advise for restriction of the pseudo-allergens and the food additives. Anyways, consumption of these food additives is not good for our health. But the problem is that it's very difficult and it's very impractical to restrict this food allergens and food dyes because they are everywhere. So it is very difficult practically, but this is something we may try in such patients. But blanket restriction of food items, it is never recommended. We have had multiple talks also during the conference. We were all there, and I think this is absolutely clear. There is no confusion anywhere that blanket restriction of food items should not be done in case of urticaria patients.
Thank you,
Thank
Dashish.
you.
So this was the last guidelines, Kiran sir, and you have already given us some glimpse about that guidelines. Now this used to be spoken like we do adjust, assess, and act. Kiran sir, they spoke briefly about that. This is little complicated, and they will short it in down. Any idea whether the manuscript will have less? Like we don't want to take the adjust part out, rather we'll assess and act. Hello?
Sir, you're muted.
Yeah, the draft does show this thing, but obviously the final manuscript will take some time to come. So till that this remains, but obviously they plan to take out one. Yeah, but this is what important. The complete control.
So so this also will be remaining in the present
Yeah.
guidelines, how we step up and step down. So can you, sir, briefly explain this to our viewers?
Yeah, so UCT is a 4 test. It shows how your urticaria is well controlled in last 4 weeks. So there are questions, you have to answer 5 questions, and typically the answer is 16 is complete control of disease, and if patient got UCT of 16 for 2 months, then you can think of reducing. If UCT is less than 12, that means the uncontrolled disease, you need to increase the dose. So that is the way it goes. So typically you have to ask how your disease is responding in last 1 to 2 months, and accordingly you take a call. Don't be in a hurry to reduce. So most of our young dermatologists try to reduce it very fast, and then patient lands up to other doctors. So please wait for 2 months before you think that patient is got complete control, and then reduce. That is the best way, because the disease is going to last for years, and don't be in a hurry to step down. So that is what is will be there in these guidelines also. Thank you.
Thank you, sir. So fast line of management in CSO industries, this was second generation antihistamines. Do you anticipate any changes? Not only in the second generation antihistamines, they have some we see relaxation for first generation antibiotic? Do they suggest that we need to still do for the times of dosing?
No, I think there is not much change, at least in the first line of treatment, that we start with second generation antihistamines and we can updose up to a maximum of 4 times if the patients remain refractory before shifting to the next step. And so updosing remains the same beyond 4 times. In fact, they have already removed the question because there is now multiple evidence that updosing beyond 4 times is not recommended. There can be adverse effects. So 4 times is the maximum limit up to which you can updose. Combination of antihistamines is actually quite interesting, which we do very often in India and in this part of the world. But this is something which is not there in the guideline. You must remember that we had lengthy discussions on this topic, especially people from Asian countries, South American countries, African countries, where this combination of antihistamines is very much prevalent. But I think this was chucked out from the guideline, and it remains the same that we do not combine. Rather, we updose the single antihistamine up to 4 times its standard dose in case of refractory patients.
Then, sir, this is somewhere possibly Indian guidelines and international guidelines do not merge. So
Yes, I think that is
can
very
you,
important, that we need to hold our individuality. Is something.
Kiran sir, what is your comment on that?
Yeah. So there's always a discussion that same medication is 4 times, but we have realized and understood that if I give same tablet 4 times, Dr. Google will immediately come and tell me that this is not right, you don't know. So it's better to give 2 in the morning and 2 in the evening. Although data is less as compared to the same tablet 4 times, but obviously our older guidelines did mention about the combination. So we do use typically bilastine and fexofenadine are the one we suggest in the daytime because of the sedation value is almost less. And night time they can use cetirizine or loratadine or this thing. You can give same bilastine also in 2 tablets in the morning and 2 in the evening, no problem. They are safe. So that should be actually important that patients must get 4 tablets of antihistaminic before a doctor says that this patient is resistant to treatment or something beyond. So this is important for all the doctors to understand that please give 4 tablets before you say that my patient is not responding. Dr. Abhishek, there are more than 7-10 questions by the audience, so we can.
I have kept last 10 minutes, sir, for that.
Yeah. So because
So,
interesting that we must give them this thing, right?
What do we know that 4 times updates they gives at least 85% of your patient will give very good response with 4 time elevation. So you just have to kind of scratch your head for 17% of the total patient of urticaria that will come to you. So updosing is must. Uh, Preferably same molecule 4 times because these are inverse agonists. So combining two may not be the exactly same. However, sometimes in India, because as I said, we are in a very dicey country where a lot of Google searching comes, and that's why you can modulate regarding that. But that's not what international guidelines suggest. Our old Indian guidelines suggest that we can combine. Bilastine, as I mentioned, and fexofenadine are non-sedative completely. So these are possibly preferred, especially when you are updosing. Senil sir, I'll come to you regarding omalizumab. You have been using omalizumab for a long period of time. In last guidelines, there is a mention of updosing omalizumab. Is there any mention of updosing omalizumab in these guidelines?
No, in this one also they said like they have not it's just like the last guidelines only. The updosing what they said is you can either increase to 450 mg if you want to give, or you reduce the duration of giving omalizumab. That is, rather than giving at 28 days, which is usually given, you can give at the end of 15 days itself. That is the one they have considered. One more thing about bilastine also, we have seen that although people say it does not cross the blood-brain barrier, we have seen few of our patients, especially when we updose bilastine, they do have some amount of drowsiness or not able to not drowsiness per se, not able to concentrate in their work. We have accumulated this and we have published in IJDVL. So there you can find things. So especially ask the patient, especially updosing a bilastine, see if they are actually happy with that. At least you can give 4 times the dose of levocetirizine or some fexofenadine if you don't want to give bilastine, if they're not tolerating bilastine.
So basically, this there's a do penetrate blood-brain barrier, but there's a pump which kind of push this efflux pump which takes it out. But these pumps work to certain extent when all these data are generated in the standard dose of bilastine. But when you updose, there's a chance that then this pump is not adequate enough to completely pumped out or efflux all the
This one thing this one thing we have noticed. So especially when you're updosing a bilastine, be careful and ask the patient if they're having the same problems.
But good thing about what I know that this patient is really suffering from urticaria, and because he has so much of histamines in their body and so much of upregulated receptors. So at that point of time, they may not feel that sleepy. It's just when the symptoms start getting controlled, they start getting more sleepiness. It's my personal idea, my personal observation. I'm not sure other people see the same thing or not. Kiran, I'll come back to what are the new. I mean, you already mentioned the new thing in the second line of treatment is remibrutinib and dupilumab. I'll come to the dupilumab first because it's the only molecule which is available in India. Though very restrictive, very expensive, but still it's available in India. So, any experience of using dupilumab in CSU patients? Kiran sir?
Sir, you're muted, sir.
who have got comorbidities, like asthma, rhinitis, atopic dermatitis, they do well with this. And the guidelines clearly mention those patients who are not responding to omalizumab, you can give dupilumab. So typically, that's the way it is. But time will tell us. So for this thing, but I do believe omalizumab is still the better amongst the two. Thank you.
And also a less expensive Indian context
More
because
cheaper.
Cheaper, yeah. Biosimilar is available, which is one of the most economical one available with us.
I'll come to so this is a very nice data about dupilumab. This shows that it's keep it A and keep it B studies. They shows that's a very good response compared to the placebo. But then when you pick up the refractory ones, we don't. I think most of us doesn't have enough personal experience to suggest regarding that. But remibrutinib can be. A lot of people believe Sunil sir, it can be a game changer. So can you just detail how does it work? Is it approved? Or what stage of approval it is there, and how which kind of CSU patient would like to use the molecule?
Mute.
Sunil sir?
Senthil,
Sunil
mute.
sir?
Yes, Bruton kinase is an I think it is there within the cytoplasm of the mast cells. It is a downtrend enzyme. So this acts by inhibiting that enzyme. So thereby preventing the release of the antihistamine from the mast cells. And there are very good phase 2 trials which has been published in Lancet recently by about phenobarbital and things and all. And as of now, in that last guidelines, we think the people are there are many posters also which was put on remibrutinib, and people were showing a very good improvement in the people who are refractory to in a chronic refractory urticaria. This probably works on the type 2, that is a type 2B endotype of
That's it.
urticaria, and it has helpful in autoimmune disorders also because it acts on the B cells also.
Fantastic. Yes, and a lot of people may remember from their undergrad day that there has to be gluten agglomaglobulinemia as one condition, immunodeficiency. That is exactly this is the where the mutations happens in those things, and this is gluten tyrosine kinase, where if you can control inside the mast cells, and then you have less chances of developing. So this can be just disease modifying. We are not yet to this in phase 3 trial. It's not yet approved, but a lot of people believes that it will be approved very soon. The data are very interesting. Kiran sir, I'll come back to you and I'll take opinion from all of you. Now this is the Indian guidelines. Now that international guidelines is published, I'm sure sir, you and other people will think about writing the next one. Where do you really see changes from our earlier guidelines?
Yeah, basically new molecules we can get, and even a tofacitinib could act as a additional table because it's economical. In fact, it has become so economical now. It is economical than one cup of tea if you if you're not aware. So it may come as an add-on therapy because Indian patients can't afford the costly medicines. And there are a few more changes we do expect. Obviously, time will tell us, but I do expect few more addition to the third line. Thank you.
Thank you, sir. Any other suggestion like dupilumab, which can come in because it's available in India?
Yeah.
Pendil, sir?
No experience of me with dupilumab.
Exactly. We
No,
can't
I mean,
really
do you,
fine on that.
maybe in these resistant patients, dupilumab, since it's available and some of the institutional practice is available. I think it's available in army. So all those people can, try in some patients. Well, I have given only one patient and could kind of go good result, but this patient also had atopy. That's a good thing about that.
Of it being helpful, but personal experience means there is no personal experience of mine. That's it.
I'll just briefly come to Indashish that you are possibly creating the next guidelines for children management of urticaria in children. Did they kind of discuss anything about how the new guidelines will shape up for children? Any new suggestions that it could be changed? Last guideline states like this that you can follow the same, but there are problems like especially when you add remibrutinib, it's will not be approved for 18 years and below. So, do you think there will be some changes, or you will just
I think
stick to the same?
in this it almost remains the same because we have already received the draft and this is the only question which is there. But I think what's interesting is about dupilumab because you mentioned about the Cupid trial. So there is also another trial which is ongoing, the Cupid Kids. So basically, there dupilumab is being tried in children more than 2 years. So after 2 years, dupilumab is being tried. So the lower age limit of dupilumab is gradually getting reduced. I think that's one interesting option. And regarding this newer molecules like the BTK inhibitors, even the JAK inhibitors, they don't have any credible evidence in children. And another thing which I can mention is because we did a review on the pediatric urticaria, that omalizumab, it's very interesting that omalizumab is approved for bronchial asthma, 6 years and above. However, for chronic spontaneous urticaria, it's for 12 years and above. So the 6 to 12-year age group, it's somehow not there in urticaria, but it's approved in children with asthma more than 6 years. So I think that's
Something happens
something
because if the drug is out of patent, they don't see. Omalizumab initially was made for asthma and they didn't work that well.
No,
Take audience
actually
question
it's
now.
for
Take
asthma.
audience question. We have just
Yes,
5-10 minutes
yes.
left.
Yeah.
We'll talk about
So I think
organ.
we
More
can
than
shift to the
50
audience
questions I'm
questions.
seeing. Take the name,
So-
who has written, and take the questions.
Yes,
That
yes,
would be
Yeah,
better.
yeah. So,
We have to give justice to
thank
those
you.
who are-
yes.
Thank you then. So I'll try to take the questions. I couldn't see
Yeah,
that questions. Is
Yeah.
it there in chat?
It's in the
or
chat.
where it is?
WhatsApp.
Sir,
so
do you
first
want
WhatsApp chat.
Oh,
Yeah,
acha, WhatsApp. I didn't
Sir,
see the
do you
WhatsApp.
want me to start or you will
Yeah,
start?
Dr. Prasad, you start the questions.
Yes, I will start.
And
Yeah. From Dr. B. Jyoti, the first question is, what is the efficacy of histoglobin injection?
yeah, so there is a lot of work going on, and we have published one study. Obviously, action is still not completely understood, but when you give the injection, it does reduce the severity of urticaria. We can reduce the dosing. That is what we published with few years back. Obviously, it is not some radical treatment, but add-on treatment once a week for 3 to 6 weeks does reduce the intensity. Obviously, there are not many studies, but just now we have just published one review on this, that it works definitely to reduce the intensity of urticaria. Thank you.
The next one is from Dr. Arushi Mittal, which is the best antihistamine for CLD plus CKD patient?
The patient is more than 6 years, then it's possibly bilastine. If the patient is more than 2 years, then it's possibly fexofenadine.
Fexofenadine, that's right. Fexofenadine has been tried for so many years.
But levocetirizine is something you need to avoid in patient of CKD.
Okay.
Otherwise, very safe drug, levocetirizine is something you need to avoid in patient of CKD.
And this is from Dr. Priyankar Mishra. Autoimmune urticaria, should I use tofacitinib? If yes, what is the dose?
Kiran sir can take the question.
We have just published, Abhishek has published the study. See, as on today, this is the most economical immunosuppression available in India, economical than cyclosporine. It has got no organ-specific toxicity. That is the advantage. Obviously, it does have side effects. So you need to rule out tuberculosis and infection. 5 milligram twice a day should be a dose. It is not as fast as cyclosporine, but it does work in reducing itching. And obviously, being available easily and economical, people will use it. But please rule out infection, tuberculosis before you start. And it could be an add-on therapy for your treatment. Those who cannot afford cyclosporine or omalizumab. Thank you.
This is from Dr. Anup Goswami. Please elaborate about weekly pulse of cyclosporine.
Senthil, the PG has just published. So just tell us what are the studies. That was for psoriasis, I think.
Yes, it was a study published on psoriasis where once the patient has been controlled, cyclosporine is that drug where you get a relapse of the disease per se. So in order to give a maintenance dose, we had studied about giving 5 milligram per kg body weight of cyclosporine at weekends and try to maintain the disease per se. So the paper was on that.
This one is from Dr. Anup Goswami. Please elaborate about, Dr. Srutika Singh. Do we need to investigate for autoimmune causes of recurrent urticaria?
So that's what basic thing, whatever you said, was the thing was anti-TP or something if you want to do. Otherwise, no other special.
This recurrent urticaria may be recurrent acute urticaria. If it's recurrent acute urticaria, then you don't need.
Okay.
Recurrent urticaria, you can acute urticaria can be other things like in children is viral, can be food. This is one area where food can be issues, but only in case of chronic urticaria where urticaria is happening daily or nearly daily, then autoimmunity can be one issue in about 20% of the patients.
Just to add here, just please, when a TPO becomes positive, you do not worry, you do not do any extra investigation. Positive TPO is an indicator of autoimmunity. That's all. You have to understand that patient is got an autoimmune nature. He may have associated autoimmune disease, but you don't have to do anything extra. Just give treatment, and maybe autoimmune patient need longer treatment and more immunosuppressants like cyclosporine.
Dr. Rajeshri Bhange again. Cyclosporine for how many days in urticaria?
See, typically we can't first week you can give first month 3 mg per kg, next month 2 mg, then third month 1 mg reduce, and then as Senthil has said, weekly pulse you can give 200 mg or 300 mg every Saturday, Sunday to reduce the side effects and reduce the cost. So that's the way. It is not yet published yet, but it is already published in psoriasis and atopic dermatitis. Thank you.
From Dr. Karan Shah, how to counsel patient regarding duration of treatment? Should we advise food allergy test in specific cases? Does it have any role in management?
Indrashish.
Yeah, I think how to counsel regarding the treatment, that is good. But I think what we need to say and what is being said is that we need to treat the patient till the disease is gone. In fact, it's not only the disease is gone, as Kiran sir has absolutely mentioned that at least for 3 months. So that is when we should think of downgrading the antihistamines. So let's say we are treating a patient of urticaria and after 3 months, the patient becomes symptom-free. So UCT score becomes 16. We do not stop at that time. So this is very important. We continue for another 3 months at the same dose. And even after 3 months, if we find that the UCT remains 16, the patient says that I don't have any wills, then we can think of downgrading the antihistamine. What I personally do is that I give it an alternate. So there are many ways you can do it. So I give it an alternate days for 1 month and then twice a week. And I just tell to the patients that just you need to find your lowest possible dose and you need to continue in that dose and gradually you need to get off the antihistamines. Now regarding food allergy testing, there is, I don't think there is any role because, it affects only 2% of patients and that's a very, very minority. In refractory patients, you can't do anything. Just try to give them a pseudo-allergen-free diet. You try to reduce them of the food dyes, food additives, etc., and that will be beneficial in most cases. Thank you.
Basic thing, it should be nailed that chronic spontaneous urticaria is an endogenous disease, nothing from outside.
Yes, absolutely.
The allergic disease, what that allergic food is to stop the triggering the worsening of the disease process. That is the only thing. It is not cure if you stop that food. It will decrease the worsening of the disease process. That's it.
Exactly. So that's an endogenous allergy. I think that's how we can put it. It's an endogenous allergic disease.
सर बोलते हैं कि आपके खून में ही आपकी दुश्मन है. Mention that to the patient.
There are 2-3 more things.
Yes. Dr. Rajeshri Bhange was asking, in recurrent angioedema, which lab investigation should we expect? CBC, thyroid profile, serum IG? Should I do C3, C4? Treatment for recurrent angioedema.
Until hereditary angioedema, just tell us please.
The first thing is whenever you are treating angioedema per se, first make sure whether it is histamine mediated or bradykinin mediated. Okay, try to ask when did it start. Usually hereditary angioedema starts in the very early in the childhood. Okay, very rarely only somewhere in the midway it comes. Second one, any family history is there. Third one, systemic involvement, especially abdominal pain will be there, involvement of the intestines will be, the intestinal edema will be there, because of which it will be acute. One thing what we can say is we need to find out hereditary angioedema first, because that can kill a patient rather than an histamine mediated angioedema. So the emergency of action should be there. If one is confirmed that probably this is hereditary angioedema, very simple test of C4 is enough. C4 is usually low in hereditary angioedema. And if you still again want to confirm, you can do the C1 esterase inhibitor levels. So this will be the simple way to get the thing to rule out HAE. If it is a normal histamine mediated, we give a bislone that will be able to take care of the crisis.
So it's from Dr. Pachiti Tekar. 4-year-old child.
One thing I just want to
Yes,
add.
sir. Yes, sir.
And this is all about when angioedema happening without urticaria.
Okay.
Even if a recurrent angioedema coming with urticaria, then you treat it like an angioedema to urticaria. The first question one should ask in a patient, adult patient, or in any patient with recurrent angioedema, whether even if there's no urticaria, just ask whether the patient is taking an AC inhibitor.
Okay.
Many times this AC inhibitor, because hereditary angioedema and are extremely rare conditions, even acquired angioedema. So first rule out the more common, and that will be AC inhibitor. Once you have ruled that out, then you do all the testing. You can see for C1 stress level, that function on not level is not good enough. Also, you need to do function to sub-classify between the two.
Correct.
So that thing you can be done later.
Last two questions, I think.
Yes. Dr. Prachiti had asked, 4-year-old child urticaria since 3 years, controlled till taking antihistamine, again reference, how to manage such child?
See, urticaria typically can don't try to reduce the dose as fast as possible. It takes time. On an average, chronic urticaria in children lasts for 1 to 3 years. So give antihistamine, which is very safe. They can give bilastine syrup also is available, or fexofenadine syrup. Typically, as Indra said, you try to reduce it. You give for 2 months daily dose 5 ml, then next 2 months 2.5 ml, then next 2 months alternate day, and try to reduce it slowly. Don't suddenly stop because urticaria may recur. Typically, it lasts for 1 to 3 years. Thank you.
Dr. Rajeshri Bange is asking, my one patient, 1-year baby, has serum IgE more than 5,000. He was on top feed from first day of birth. We stopped top feed and is relieved from his urticaria. Observation.
Yeah. Actually, it is, yeah, obviously atopic, it's atopic nature. The 5,000 IgE means the child is atopic child. That is for sure. But I don't think it has got any relation with breastfeeding and urticaria and children urticaria. Indrashi, anything you want to tell?
No, I think breastfeeding reduces the chance of these atopic disorders. Possibly this is the link. A child was on top feed from day one, and not receiving breast milk might have aggravated this atopic conditions. But as it is rightly said, it's an atopic child. So I think that's how we should see.
Breastfeeding actually is a very relationship with atopic disorders. If you continue breastfeeding for prolonged period of time, there's a chances of atopy actually increases.
Okay.
So that's something we need to keep in mind. So a lot of people who change it, continue for more than 6 months, that actually increases. And one thing you need to understand is that these diseases has a this is an auto death, you can say. These diseases gets cured on their own. So there can be odd possibility of observation of some patients. This can be coincidental rather than actually something more effective.
This is very actually statistically insignificant. So
the question is, what is the dose of omalizumab in CSU?
Standard dose is 300 milligrams subcutaneous every 4 weekly. In certain patients, you can increase up to 600 milligram or every 15 days 300 milligram. Either way, that's for the more omalizumab refractory patient or delayed responder to omalizumab.
This one is from Ajita Bagai. Ophthalmologists do not want us to give antihistamines to glaucoma patients. What are the recommendations from all of you?
See,
no. This is about
side effects. Yeah, the newer side effect doesn't have a side effect. Yeah, Abhishek, tell.
This is a fast generation antihistamine. So we need to clarify that fast generation antihistamine has the problem of this cholinergic side effects and everything. So second generation antihistamine has a very, very safe nature and this doesn't very specific receptor binding. So these are absolutely safe even in glaucoma patients.
Dr. Vivek Pandey is asking, any role of probiotics?
Yeah, Abhishek, just 2 lines.
Not yet proved, so we should not comment. But there are some association between gut microbes with urticaria and atopic. Both have been reported, but since we will not recommend using probiotic for treatment of urticaria for sure.
Dr. Vivek Pandey is asking, if CSU patients respond to oral tofa, how long it can be prescribed?
Yeah, see,
no guidelines per se, that depends on
exactly. You gradually taper down after 3 to 6 months, 1 BD to 1 OD, then after 3 to 6 months, half, and then try to stop it. But it is tough job, but obviously you have to slowly taper.
Well, I think that's
3 to 6 months, we need to keep the patient on tofacitinib because you need to understand the patient already has an autoimmunity. But do understand that you need to taper down tofacitinib, but keep the antihistamine going. So our main idea is we have to keep the second generation antihistamine going and stop
These are all
the
add-ons.
immunosuppressor.
They're all
Thank
add-ons.
you. Thank you very much.
Yeah, that's all questions. Thank you very much. Thanks, Dr. Kiran.
you.
Thanks all the panelists. It was a lovely discussion. I mean, I'm sure the audience must have benefited from this. Thank you. Thanks all of you. Thanks all the
Bye-bye.
participating doctors who took time from the schedule and attended this. Thank you, marketing team for conceptualizing and sales team for organizing. And thanks IT team, Hetero, for the super coordination. Thanks all of you. Thank you so much.
Thank you.
I wish
Thank
you a
you.
very
Thank you,
pleasant
sir.
evening.
Thank you,
you.
sir.
Thank you.
Thank you.
Bye.
Thank you.
Shashidhar, I'm leaving. Huh?
Thank you, sir. Prashant, sir.
Thanks,
Thank you.
thanks, Samantha. I'm in office tomorrow. Anything